Welcome back to the deep dive. Today, we're not just stepping into the OR. We're really heading to the engineering floor for a blueprint of the kneecap. We're talking about, I think, arguably the most demanding joint segment in all of orthopedics, the patellofemoral joint.
That's absolutely right. And you should think of this as, well, mandatory grand rounds or maybe our pre-op huddle. Our topic is the in vivo kinematics of the patellofemoral joint. And our mission really is to take these dense academic papers, the ones full of vectors and coordinate systems, and actually translate them into a surgical blueprint we can use. We have to know the math to survive the clinical challenge.
Because let's be honest, getting perfect patellar tracking in a total knee arthroplasty, a TKA, it often feels less like science and a bit more like luck. Patellofemoral pain, or PFP, is, well, it's the bane of the TKA surgeon. The diagnoses are vague, and the big decisions, do we resurface the patella or not, are so high stakes.
They are, and they're controversial and just so deeply rooted in these complex biomechanics. We are diving deep into the engineering specs of this one little sesamoid bone.
Oh.
We need to understand how it moves in vivo. How it actually behaves under real high physiological load, not just what you see in a cadaver lab.
Right.
When we fail here, it's not a minor complication. We're talking chronic anterior knee pain, a high chance of early component failure, and that means revision surgery. The stakes couldn't be higher.
Okay, let's unpack this crucial little bone, the patella. This high-octane sesamoid is really the central engine of the whole extensor mechanism. It gives all the leverage to the most powerful muscle group in the body.
It is the ultimate biomechanical lever, and its importance, it's been recognized for centuries. If you go all the way back to John Sheldon in 1789, he gave us the analogy that we still use today. He described it as a rope and a pulley.
Still holds up.
It does. That simple mechanical setup provides a huge advantage, massively increasing the moment arm of the quadriceps.
But of course, every great discovery has its dissenters, right? It's almost wild to think that in 1937, Brooke actually challenged the whole function of the patella. He suggested that a patelectomy, just taking the bone out, could somehow improve performance.
Yeah, that really highlights how much we still had to learn about biomechanics back then. Thankfully, kinematic research stepped in. The absolute key fact check here, the one that should guide every single decision, is that preservation is the goal. Losing that sesamoid is functionally devastating.
And the data is just overwhelming. If you look at figure 18.1, which shows the moment arm length, you see exactly why. A patelectomy decreases the extensor mechanism moment arm by a staggering 14%.
And that 14% drop is not minor. It cuts the overall power output of the quad by at least 15%.
Wow.
So if you lose that kind of power, you can't achieve full terminal extension. And that's essential for walking, for getting out of a chair, for climbing stairs. The moment arm is everything.
That puts the demands on this bone into perspective right away. Let's talk about the sheer technical detail, the loads. This tiny sesamoid has to withstand these incredibly high joint reaction forces. What are we talking about in terms of body weight?
We're talking extremes. When you analyze activities like deep squatting or aggressive stair climbing, the patellofemoral joint reaction forces can hit onto 12.9 times body weight.
12.9. That is an insane load-bearing requirement. To put that in a framework we can see, it's like a bumper car on the femoral track. It just gets slammed with force, and it needs the best possible lubrication and material strength to survive that ride.
The bumper car analogy is spot on. It really emphasizes the impact and the sliding, and what makes that near frictionless high-force transmission possible. It's the unique biology. The patella is covered by the thickest layer of articular cartilage in the entire human body. We're talking 4 to 6 millimeters thick at the center.
That thickness isn't an accident. It's an adaptation to distribute those, 12.9 times body weight forces over a bigger area. The combination of that elastic cartilage, which is like a shock absorber, and the super lubricated synovial fluid, it just allows for this force transmission with an astonishingly low friction coefficient. It's a biological masterpiece.
And when that masterpiece starts to break down, which is what patellofemoral arthritis is, that's when we have to step in. But to do that effectively, we first have to understand the native joint blueprint, the complex mechanical environment we're trying to replicate, often with materials that are, frankly, fundamentally inferior to cartilage and bone.
Let's start with the hard boundaries then.
Yeah.
The geometric controls, the osseous structures of the trochlear track. What actually defines that stable path?
We're looking entirely at the geometry of the femoral trochlea. So key features would be the lateral trochlear inclination, or LTI, the sulcus angle, so the depth of the groove, and then the overall groove width and length. These are the physical rails that dictate the motion.
And the research points to this fascinating evolutionary design shift. It moved away from symmetry to achieve stability, right?
Absolutely. The trochlear geometry has evolved quite a bit. It shifted from a pretty symmetrical, shallow groove to one with a really prominent lateral inclination. If you picture the patellar tract, the groove itself is aligned proximal lateral to distal medial.
And the whole point of that increased lateral wall is what?
It's an explicit engineering feature. That increased lateral inclination is designed to forcefully catch the laterally tracking patella early in flexion. It prevents subluxation, and that dramatically increases medial lateral stability. Without that prominent lateral wall, the patella would be incredibly unstable, given the huge lateral forces on it.
Ah, so that's the built-in safety rail. If the native trochlea is like a custom-molded ski run with a high-banked lateral turn for stability,
Yeah.
then a poorly designed implant, or worse, an internally rotated one, is basically a flat, symmetrical bowling alley. The slightest lateral vector, and the patella is in the gutter.
That's a great analogy. It immediately fails the stability test, which brings us right to the source of that instability, the dominant external force, the Q angle and soft tissue dictation.
The Q angle, the quadriceps angle, that's the key variable here, defining the relationship between the quad's line of pull and the patellar tendon. You can see it in figure 18.2. What's the relentless bias we're always fighting against?
The bias is always lateral. Because of the width of the pelvis and the position of the vastus lateralis, the quad's line of action is naturally superolateral. It creates this persistent, outward-directed horizontal pull. Every single movement you make, the quad is trying to pull that patella out to the side.
Okay, so if this massive quad group is constantly pulling the patella laterally, what are the counterforces the native knee has to keep it centered and stable?
It relies on two main counterforces, both anatomical. First, the osseous constraint we just talked about, the anterior projection of the lateral condyle, which we quantify as the LTI, that's the static bony block. Second is the soft tissue counter, the insertion of the vastus medialis, specifically the oblique fibers, the VMO.
The VMO. That muscle is the true sacrificial lamb of stability, isn't it?
It really is. The VMO fibers reach much more distally compared to the vastus lateralis. That distal reach means they can provide a really effective medializing pull in that critical early flexion range, from 0 to 30 degrees, where the patella is most vulnerable. These bony and soft tissue factors are the only things fighting that powerful lateral pull from the rest of the quad.
That makes perfect sense. So we have this complex three-dimensional motion happening under extreme force, driven by these opposing forces. To study this properly, we need a consistent language. Which brings us to standardizing the language of motion.
Yeah, and this was a huge hurdle in the early research. It led to significant discrepancies in data. If one lab measures tilt one way and another lab measures it differently, the results are clinically useless. We needed a unified coordinate system.
And this is where we owe a lot to the engineers. We rely on the ISB standard from 2002, which is based on the principles laid out by Grood and Sunte way back in 1983.
So let's quickly run through the 6 degrees of freedom relative to the femur. You can see this in figure 18.3. This is the language of our analysis. You've got 3 translations, which are shifts along an axis, anterior, posterior, medial lateral, and proximal distal. Simple, linear movements.
Right. And then the 3 rotations, which are way more complex because they're interconnected. So you have flexion extension, which is about the medial lateral axis. You have medial lateral tilt, about the proximal distal axis, and medial lateral rotation over the anterior posterior floating axis.
And the key technical note here, why adopting the ISD standard is so important, is that it ensures these rotations are calculated in a way that is sequentially independent.
Why is that technical detail sequentially independent so critical for us?
Because if the measurements were coupled, meaning if measuring tilt somehow affected the calculation of rotation, you would introduce these mathematical errors that could hide or inflate the true movement. By making them independent, the rotation calculation is consistent no matter what the tilt is. It just ensures the kinematic curves we generate and study are reliable and consistent. That's the foundation for evaluating TKA performance.
Right, a solid foundation, which is essential as we move from the beautiful complexity of the native knee to the messy reality of the surgical minefield, the challenges we face trying to replicate this with metal and plastic.
And the biggest, most common cause of TKA failure and anterior knee pain is directly related to malpositioning. This almost always leads to pathological maltracking, which we usually see as lateral patellar subluxation.
And when that happens, the traditional, and let's be honest, often a reflexive remedy has been the lateral retinacular release, the hammer, as we sometimes call it, the go-to fix for leftover lateral tension.
It is, but we need to stop thinking about the hammer and focus on the nails. The specific, preventable, intraoperative errors that cause this maltracking. Every resident needs to have these burned into their brain. Internal rotation of the femur, internal rotation of the tibia, overstuffing the patella, and lateralization of the patellar component.
Let me push you on that for a second. If you had to pick one of those errors that guarantees a catastrophic outcome, what's the prime villain? Is it the internal rotation of the femur, or is it just gross overstuffing?
That's a great question, and the literature consistently points to rotational mismatch, specifically internal rotation of the femoral component. While overstuffing definitely increases contact forces, internal rotation of the femur is kinematically catastrophic. It flattens or even reverses the orientation of that critical lateral trochlear wall relative to the patella's path.
So by internally rotating the femoral component, we're basically removing the primary constraint that evolution designed, that LTI. We're essentially derailing our bumper car before it even gets into the groove.
Exactly, you've eliminated the safety rail, and while a retinacular release can address the symptom of tension, the research also notes that some patients will still maltrack no matter what, just due to high patient variability and stiff soft tissues. But fixing that rotation is absolutely non-negotiable.
Okay, let's move to another huge but sometimes missed cause of failure, joint line elevation. The source material calls this a kinematic catastrophe, especially in revision TKA. Why is restoring the joint line so critical?
It is the absolute foundation of the entire extensor mechanism. If we don't restore the native joint line, we immediately change the relationship between the patellar tendon, the joint axis, and the quad insertion. Elevation can happen from distal femoral bone loss in a revision, or more commonly just overstuffing the tibiofemoral gap with components that are too thick.
And if the joint line is elevated, that creates what we call pseudopatella baja. It mimics the functional problem of a true low-lying patella, even if the tendon length is normal.
And the consequences are enormous. First, you get a significant decreased moment arm. Functionally, this means the patient really struggles with low flexion activities, getting out of a chair, going upstairs, because they've lost mechanical advantage right where they need it most.
And what happens in deep flexion?
You introduce potential patellotibial impingement. Because the joint line is high, the patella, as it dives deep into flexion, can scrape against the top of the tibial component or the tibia itself. This causes chronic pain and severely limits their range of motion.
And on top of all that, we're amplifying the destructive forces on the implant itself. Joint line elevation causes tibiofemoral and, critically, patellofemoral contact forces to just increase dramatically.
Yeah, like overloading that patellofemoral joint just skyrockets the risk of component wear, degeneration, and eventual failure. To go back to an analogy, it's like setting the foundation of a building. If you lift the entire first floor, elevate the joint line, the whole superstructure, the kinematics above it, just goes completely haywire. Restoring that line is mandatory for long-term survival.
Okay, now let's look at a design solution that tries to self-correct for some of these errors. The difference between mobile versus fixed-bearing TKA. This is where smart mechanics can help compensate for our surgical variability.
This is a fascinating area, and the source material is really clear that the ability of that tibial insert to move the mobile bearing offers a significant, measurable kinematic advantage, especially for the patella.
The core advantage being the mobile bearing insert's ability to self-align with the femoral component. Can you walk us through the mechanism there? How does that actually protect the patella?
Sure. Think about it. You place the femoral and tibial components, and there's always some small, unavoidable rotational mismatch. In a fixed-bearing knee, that mismatch locks the tibial tubercle into a position that might increase the Q angle, forcing the patella laterally. In a mobile-bearing design, the polyethylene insert can rotate slightly on the tibial tray.
So the plastic insert rotates to meet the femoral component's path, basically buffering the rotational error in the tibia itself.
Exactly. By self-aligning, the mobile insert kinematically centralizes the entire extensor mechanism. It stops that excessive lateralization of the patella that you get from component mismatch. It absorbs the rotational stress before it even reaches the kneecap.
And the clinical data actually backs this up. Yang et al. Showed that the need for that hammer, the retinacular release, was significantly reduced in mobile-bearing designs compared to fixed-bearing ones.
That finding is huge. It suggests that if you choose a mobile bearing design, you're building in a margin of error that compensates for those small, often unavoidable rotational mismatches. Fixed bearing designs can't correct. They transfer the full force of that error, which leads to a lateral tibial tubercle, a bigger functional Q angle, and a greater lateral force vector on the patella. The mobile bearing is essentially a self-correcting alignment tool.
A brilliant piece of engineering to mitigate human error. Now we're moving into Section 3, the great debate patellar resurfacing. This is the classic orthopedic controversy, which the source material rightly calls synonymous to topics of religion or politics.
The debate has been going for decades because the stakes are high and the data isn't clear-cut. There are really three basic camps. 1, always resurface. 2, selectively resurface based on what you find in surgery. And 3, never resurface.
Let's start with the purist, non-resurfacing. The main argument here is that by leaving the native patella, you maintain more physiologic kinematics and, crucially, you eliminate the risk of all the errors that can come with prepping the patella and positioning that little button.
That's a strong argument, especially given how sensitive the joint is to thickness and position. But, and this is a big but, this strategy has a non-negotiable caveat. The research is crystal clear. If you choose not to resurface, you must select a patella-friendly femoral design.
Why does the femoral component choice become so critical when you leave the native patella?
Because most modern femoral components are designed to articulate with a polyethylene implant, a smooth, domed button. They are not shaped for native patellar geometry. If you use a non-friendly component with a native patella, you're asking for trouble. Maltracking, pathological tilt, and maybe worst of all, mechanical impingement of that retropatellar ridge against the metal intercondylar notch of the femoral component. It's an engineered incompatibility.
So if a surgeon preserves the patella but uses a standard non-friendly femoral component, they're basically accepting a built-in risk of failure from poor articulation.
Precisely. They're trading the risk of messing up a button for the risk of metal-on-bone impingement. Now, if we do decide to resurface, we enter the world of the implant design spectrum.
What are the main philosophies behind the shape of these polybuttons?
They really span from the simple, classic symmetrical dome shape to the complex, modern, asymmetrical, anatomic-based design. The symmetrical dome is often called forgiving.
Forgiving in what sense? Easier to implant.
Exactly. They're less sensitive to minor rotary alignment errors or subtle malpositioning. That minimizes the chance of catastrophic edge loading. They're the safe choice, giving the surgeon a wider margin for error.
But if the goal is to restore the most natural kinematics possible, then you'd lean towards the asymmetrical anatomic-based designs.
Absolutely. Those designs try to mimic the native patella's shape. They provide a more conforming articulation, which should increase contact area and decrease subluxation. But they have a huge trade-off. They demand an exceptionally high level of precision during implantation. If they're tilted or rotated even a little bit, the contact area plummets and the risk of edge loading skyrockets. It's a high-risk, high-reward strategy.
And then you have hybrid designs, trying to find a middle ground, like a modified dome with a concave surface for more conformity, or a medialized dome with a bigger lateral facet to actively promote more normal contact.
At the end of the day, the source material notes that despite all these designs, we still don't have a clear consensus on which strategy don't resurface, dome or anatomic, is really superior for everyone. That's why the debate is still so heated. We're making trade-offs every single time.
That sets us up perfectly to analyze the data on three-dimensional kinematics. Let's look at what movement patterns we are actually restoring and which ones are still problematic in a TKA.
Let's start with translation, or patellar shift, figure 18.4. This is the medial lateral and proximal distal movement. So where is the patella most vulnerable in a native knee?
At full extension, 0 degrees. The patella is sitting superior to the trochlear groove, pulled up high by the quad. It might not even be touching the femur. That lack of bony engagement and the big Q angle means it's most susceptible to lateral subluxation right then.
Correct. The bony rail isn't engaged yet. So as the knee starts to flex, the patella has to do something essential. It performs a medial shift through about the first 30 degrees of flexion. This is crucial for stability.
And that medial shift is coupled with other movements, isn't it?
Yes, it's coupled with the screw-home mechanism. As the knee flexes, the tibia rotates internally, which effectively reduces the Q angle. That movement helps centralize the patella into the trochlear groove, establishing stable contact.
This shift pattern is so important because it's what defines patellofemoral pain, PFP pathology. We know PFP is fundamentally linked to lateral malalignment.
And PSP patients have a distinct kinematic signature we can see clinically. They show lateral hypermobility and what we call the positive J sign, that sudden, abrupt, jerky lateral shift of the patella as the knee gets to full extension. It's a visual sign of instability.
And the data backs this up. Studies consistently show the patella in PFP patients is shifted more laterally than in healthy subjects. This is the objective evidence of the tracking problem we're trying to fix with TKA.
Right. Now let's look at the post-op knee. If you look at the data in figure 18.4b for TKA shift, the studies generally confirm the TKA patella also shifts medially with flexion, so it mimics the native movement.
But the magnitude of that shift is where the component choice matters.
Absolutely. The fixed bearing designs show larger shift magnitudes than the mobile bearing ones. This is more evidence that the self-aligning capability of the mobile bearing seems to bucker some of that medial lateral stress, leading to a smoother, less exaggerated translation.
Let's move to the most mathematically consistent movement, patellar flexion, figure 18.5. This relationship is almost perfectly linear.
It's a beautiful example of biomechanical consistency. In the native knee, patellar flexion increases linearly with knee flexion, but, and this is important, it happens at a clearly defined lower rate than the tibiofemoral angle itself.
Which leads to the formula that defines normal function. The patella flexes at about 68% the rate of tibiofemoral flexion. We use equation 18.1 to show this coupling. Patellar flexion equals 0.68 times tibiofemoral flexion plus 1.833 series.
That 68% rate is so important. It confirms the patella is lagging slightly behind the femur on tibia rotation, which is necessary to maintain the right tension and leverage. If it was a 1-to-1 ratio, the quad would be way less efficient.
And the good news for surgeons is that TKA seems to restore this gross pattern pretty well. If you compare figure 18.5a, native, and figure 18.5b, TKA, they look almost identical.
The TKA regression line in equation 18.2 confirms it, giving a slope of 0.67, so we are maintaining that essential 68% linear pattern. Even with an implant, we get the primary mechanical leverage ratio right.
Okay, next up is the transverse plane motion. Patellar rotation, figure 18.6. How do we define positive rotation, and what should we see in a healthy knee?
Positive rotation is defined as lateral rotation. So the base, or the superior pole, moves laterally, and the apex, the distal pole, moves medially. In a native knee, figure 18.6a, the patella starts neutral at extension and shows increasing positive lateral rotation as you flex.
Why does it naturally rotate laterally when the knee bends?
It's coupled motion again. It's following the medial movement of the tibial tuberosity during flexion, but that persistent lateral pull of the quad dictates the rotation of the base. The combination results in the base moving laterally while the apex follows the tibia immediately. Net lateral rotation.
And this gives us another signature of PSP pathology. Those patients show the opposite pattern negative patellar rotation. The base moves medially with flexion. If you see that, it's a huge red flag for tracking failure.
Yes, that's a key diagnostic sign. In TKA, figure 18.6b, we generally get the direction of right lateral rotation, similar to the native knee. But Anglin et al. Found an interesting nuance. Mobile-bearing TKA components rotated up to 4.6 degrees less than the patient's pre-op patella.
So we restore the pattern, but the implant geometry might sort of dampen the magnitude of rotation. It could make the tracking feel a little stiffer, maybe less compliant than the native knee.
Exactly, the plastic constrains it. Now, finally, let's talk about the most variable and difficult movement to quantify. Patellar tilt, figure 18.7.
The scatter plots in figure 18.7a look chaotic. Why is the literature so inconsistent on measuring tilt?
There are a few reasons. Historically, measurement techniques were all over the place, and the definition of the patella's coordinate system was a mess before the ISB standard. Plus, different studies use different methods. Some non-weight bearing, some weight bearing, different imaging. It's just hard to compare apples to oranges.
Okay, but despite the scatter, can we pull out a general native pattern, figure 18.7a?
Yes, generally. In the early phase, from 0 to 30 degrees, there's a tendency toward medial tilt, which helps seat the patella. That's followed by a tendency toward lateral tilt as the knee moves through 90 degrees.
And what about the TKA pattern in figure 18.7b? What's the consistent pathological finding there?
The TKA patella tends to be consistently laterally titled throughout flexion. Even with what we think is optimal component positioning, the balance is almost always shifted laterally compared to the native state. That lateral tilt is often a direct result of the stiffened soft tissue envelope fighting the unforgiving implant geometry.
And we shouldn't overlook that specific clinical subgroup finding related to tilt.
Right. Anglin et al. Made the vital observation that female patellae were significantly more laterally tilted both before and after surgery compared with males. This is likely tied to the wider Q angle and pelvic differences in the female population. When you're managing post-op pain in a female patient, persistent lateral tilt is something you have to consider.
And once again, the mobile bearing design seems to help here, mitigating that lateral tendency. Sawaguchi et al. Showed that mobile bearing designs may reduce lateral patellar tilt compared with fixed bearing ones.
It seems mobile bearings are compensating not just for rotational errors, but for tilt errors in the coronal plane too. They act as a crucial buffer, and that stability is vital. But it brings us to maybe the most critical difference between a native and an implanted knee: the contact conundrum. This is where material science meets crushing force.
Okay, so let's review the native contact mechanics, figure 18.8 A and B. We know the patella handles forces up to 12.9 times body weight. How does the body distribute that load?
Exceptionally well. At full extension, there's minimal contact, if any. Contact starts between 10 and 20 degrees of flexion at the apex, and it settles firmly within the trochlea beyond 30 degrees.
And the genius is in the surface area growth.
It grows linearly and fast. As you flex, the contact area increases from about 150 square millimeters up to an average of 480 square millimeters between 20 and 60 degrees.
And in real-world high-load situations, it's even bigger. In vivo weight-bearing MRI studies showed contact areas over 500 to 600 square millimeters. That huge surface area is how the body reduces contact stress force divided by area.
And now we introduce the polyethylene component, which leads to the polyethylene limitation, figure 18.8 C and D. This is the ultimate, unavoidable trade-off we make. The source material has a brutal number here.
It does. The contact area in a TKA is, at best, 40% of that in a normal patella. We are losing 60% of the surface area that was designed to dissipate 13 times body weight.
That 60% loss isn't just a statistic. It is the core biomechanical reason for long-term TKA failure. And why is there such a huge difference? It's all material science.
Cartilage versus polyethylene.
Exactly. Native cartilage is an order of magnitude softer and more elastic than the polyethylene we use. Cartilage deforms under load, and that's the key mechanism for increasing its contact area and reducing peak pressure. The hard polyethylene implant, though, barely deforms, so it has a critically limited ability to increase its surface contact area to spread that load.
So instead of hundreds of square millimeters of soft adaptive contact area, we're left with just high stress concentration.
Exactly. Dome-shaped components range from a tiny 13 square millimeters up to maybe 164. Even the most conforming designs only reach up to 270 square millimeters. And when you compare 270 to the native 600, you see the enormous deficit. Since polyethylene wear is proportional to stress, we are basically building in a long-term failure mechanism because the material is just too hard.
Which brings us back to that key finding in the non-resurfacing debate. The non-resurfaced patella maintains up to 79% of its original contact area.
Right, because even if that native cartilage is arthritic, it still has its natural elasticity and its biologic remodeling capability. It adapts its stress contouring to the patellofemoral component. The native tissue, even when it's diseased, is just better at distributing force than our current poly buttons.
So, resident summary. When we decide to resurface, this is the core trade-off. We gain mechanical control and component stability, which can fix acute pain and maltracking. But we sacrifice surface area protection and the biological compliance of cartilage. It's like going from a soft, adaptive rubber track to a hard, unforgiving plastic slide. We're trading long-term wear protection for immediate mechanical control.
That synthesis is perfect. We've covered the whole spectrum, from the high-force native environment and the critical role of geometry to the catastrophic stakes of TKA component alignment, especially rotation and joint line. We've also seen the data on how TKA restores gross motion, like that 68% rule, but introduces challenges in stability, like lateral tilt and most critically force distribution, that 40% contact area limit.
The core takeaway is undeniable. TKA, while it's a success story, fundamentally alters the contact mechanics because of material science. We are constantly relying on geometrical fixes like asymmetrical trochleas or mobile bearings to compensate for the lost biological compliance of cartilage. We're fighting that lateral shift and extension and trying to mitigate that persistent lateral tilt.
We're still chasing the ghost of the perfect patellofemoral interaction. And the data forces us to look forward. If patellofemoral disorders are all about kinematics, kinetics, or soft tissue, and PFP patients show negative rotation and lateral hypermobility, we have to ask, What is the next frontier for TKA design?
We've focused for so long on optimizing the geometry, the shape of the trochlea, the position of the components, to restore the moment arm from figure 18.1. But if the real limitation is the massive reduction in contact area from figure 18.8, then relying only on geometry is a failing strategy, isn't it?
Exactly. The future has to move beyond just shape fixes and toward materials. We need materials that can truly mimic the viscoelasticity and self-conforming properties of native cartilage. That would allow for better force distribution, restoring a larger contact area, and maybe eliminating that stark 60% loss in load-bearing capacity. The next revolution in TKA might not be in the metal, but in a new, compliant polymaterial.
Something to think about as you prep for your next case. The engineering challenge is far from over.
Always. Thanks for joining us for this deep dive into the engineering specs of the kneecap.
We'll see you next time.